Good morning, everyone. Today we are going to see about the topic alcoholic liver disease. We are going to students may be able to understand the clinical features, complications, treatment of alcoholic liver disease. And the definition: clinical features, causes, complications of and treatment of liver cirrhosis. Also, so alcoholic liver disease clinical features may be varying from jaundice to protein calorie malnutrition, right upper quadrant discomfort, tender hepatomegaly, encephalopathy, coagulopathy, ascites, severe malaise, and fatigue. So these are the primary clinical features of alcoholic liver disease. This is the differentiation between obstructive jaundice and hepatic jaundice. By history-wise, the patient will be having in obstructive jaundice. History-wise, patient will be having abdominal pain, fever, rigor, and prior biliary surgeries. Patient may be having physical signs of high-grade fever, abdominal tenderness, and palpable abdominal mass may be present. Laboratory wise, elevated alkaline phosphatase levels with varying degree of hyperbilirubinemia may be present. Prothrombin time that is normal or normalized with vitamin K administration. So, in a hepatic jaundice, that is the reasons in which the liver intrinsic mechanisms are involved: anorexia, malaise, myalgias, suggestive of viral prodrome, known infectious exposure, use of injections, drugs or intranasal cocaine, exposure to known hepatotoxins, and family history of jaundice. In physical signs, we may see ascites, the other prominent abdominal veins, gynecomastia, spider nevia, spiral angiomata, asterixis, encephalopathy, Kaiser-Fisher ring. This Kaiser-Fisher ring will be seen in Wilson's disease. In lab parameter wise, elevated aminotransferase levels will be seen, prolonged prothrombin time that does not correct with vitamin K administration. So these are the difference between obstructive and non-obstructive, the hepatic jaundice. So the complications of alcoholic liver disease may be of two types: acute and chronic. So acute on chronic liver failure and the chronic liver failure. The chronic liver failure is an end-stage renal liver disease, and along with these both the liver failures, bacterial infections, hepatocellular carcinoma can also be complications of alcoholic liver disease. So the primary treatment for alcohol liver disease is stopping the alcohol. This is abstinence from alcohol is the main management. In severe alcoholic hepatitis, corticosteroid therapy and pentoxifylline tablets are used. N-acetylcysteine, ursodeoxycholic acid, infliximab, vitamin E, silymarin. These are the other drugs which can be used in treatment of alcoholic liver disease. So along with this oral medications, dietary pattern is very important. Oral protein calorie supplements is a vital component of management of patient with decompensated cirrhosis, and supplements of vitamin A, vitamin D, thiamine, folate, pyridoxine, and zinc are the other treatment modalities. So for cirrhosis, cirrhosis results from necrosis of liver cells followed by fibrosis and nodule formation. This is irreversible change actually. The end result is impairment in liver cell function and gross distortion of liver architecture leading to portal hypertension. So there are multiple causes for liver cirrhosis. The main prominent causes for liver cirrhosis are alcoholic liver disease, non-alcoholic fatty liver disease, chronic hepatitis B. Other less common things are chronic hepatitis C, primary biliary cirrhosis, primary sclerosing cholangitis, mechanical obstruction, biliary atresia, cystic fibrosis. In case of metabolic disorders, hemochromatosis, Wilson's disease, alpha 1 antitrypsin deficiency, glycogen storage diseases, and hepatovenous outflow obstructions, conditions such as Buchiari syndrome, veno-occlusive diseases, right heart failure, and some other drugs and toxins can also cause liver cirrhosis, but in less common. In Indian childhood cirrhosis also a less common reason for cirrhosis, but the most common cause for cirrhosis is alcoholic liver disease and non-alcoholic fatty liver disease, and chronic hepatitis B. So these are the clinical features of cirrhosis. Maybe two types are compensated and decompensated. So what is decompensated? Compensated means patient may be asymptomatic. The liver synthetic function is mostly normal, and usually this compensated cirrhosis is an incidental diagnosis. So the decompensated cirrhosis means development of ascites, portal hypertensive, gastrointestinal bleeding, encephalopathy, and jaundice. So these are the complications of cirrhosis. Uh, so cirrhosis may lead to portal hypertension and liver insufficiency. Due to portal hypertension, variceal bleeding may occur. So, and formation of ascites, encephalopathy, and jaundice. Due to ascites, due to the presence of ascites means accumulation of fluid in the peritoneal cavity, and due to this accumulation of fluid in the peritoneal cavity, patient may also undergo spontaneous bacterial peritonitis (SBP) and may also develop HRS, that is hepatorenal syndrome. Okay. So this is the main complications of cirrhosis. So variceal hemorrhage is the most dangerous complication, and ascites, encephalopathy, and jaundice are the other complications of cirrhosis. So cirrhosis develops in this manner. It will be starting as an acute liver failure, then progress to chronic liver disease. As we discussed earlier, it is a compensated cirrhosis, for which the median survival year is more than 12 years. And after this compensated cirrhosis, after development of variceal hemorrhages, ascites, encephalopathy, and jaundice, it will go into a stage of decompensated cirrhosis. After development of this stage, the median survival age is 1.6 years, and eventually it will cause to death. So, treatment for cirrhosis is based upon the compensated and decompensated features. So, in a compensated cirrhosis, hepatocellular carcinoma surveillance is the most important thing, and variceal surveillance. You have to surveillance for the varices and do a esophagogastroduodenoscopy, or commonly known as UGI upper GI endoscopy. If there is no varices, you have to do every once in 3 years. You have to look for anything. You have to recheck whether the varices is present or not. If there is small varices, once in 2 years you are going to recheck it. If the varices is large, then you are going to treat medically with non-selective beta blockers. Example is propranolol, and if it is bleeding, ligation can be done. Then we have to monitor the INR levels, albumin and bilirubin levels, which may be deranging the metabolism of the patient. So in decompensated liver disease, monitor creatine. So in decompensated patient having variceal hemorrhage, active hemorrhages, early vasoconstrictions plus endoscopic therapy, that is ligation, must be done. Short-term antibiotic prophylaxis may be given. And, to prevent the rebleeding, you have to reduce the portal hypertension. So to reduce the portal hypertension, we are going to use propranolol plus ligation of the bleeding vessels. For treatment of ascites, main treatment is to stall restriction and use of diuretics, mostly spironolactone. And you should avoid NSAIDs, and no water restriction unless serum sodium is less than 130. Uh, if renal dysfunction occurs, diuretics can be used, and expand volume with albumin and identify and treat the conditions such as sepsis, hemorrhage, diarrhea, nephrotoxic agents. The hepatic encephalopathy is a complication of decompensated cirrhosis. Uh, we have to identify the precipitating factor for the hepatic encephalopathy, that is mostly GI hemorrhages, sepsis or infection, prerenal azotemia, and constipation. Constipation is the single most reason for development of hepatic encephalopathy in a patient with decompensated liver disease. A patient who is diagnosed with decompensated liver disease is not passing stools for more than 2 days, then he is under risk of developing hepatic encephalopathy. So for this, we have to treat him with stool softeners or laxatives. So lactulose can be given, and we have to target of 2 to 3 loose stools or 2 to 3 stools per day the patient should pass. That is achieved to achieve the target of, we have to use lactulose. So rifaximin in patient with intolerant to lactulose, those with recurrent encephalopathies are used. So summary of this clinical features, complication and management of alcoholic liver disease and cirrhosis. So alcohol associated liver disease is the most common form of liver disease, can lead to cirrhosis, liver cancer and liver failure and death. The clinical features are parotid enlargement, spider nevi, gynecomastia. We can say this as signs of liver cell failure, clubbing, deputans contractures, testicular atrophy, jaundice, loss of secondary sexual hairs. So in decompensated already discussed, it is hepatic coma, presence of asterixis, ascites, caput medusae. It is dilated tortuous veins around the umbilicus, caput medusae, edema. The primary treatment is stop alcohol. Consider corticosteroids, pentoxifylline tablets, vitamin E, silimarin, and other vitamin supplements. So cirrhosis is a dangerous form of alcoholic liver disease. Results from necrosis of the liver cells followed by fibrosis and nodule formation. So the complication is variceal hemorrhage, ascites, encephalopathy, and jaundice. So treatment is surveillance in case of asymptomatic cases, and treating with medications and surgical procedures in case of decompensated liver disease. So if the patient is bleeding, we have to stop the bleeding by ligating, by endoscopic therapy, and by medically you have to reduce it portal hypertension by propranolol. The patient is having ascites, we have to give salt restriction, usage of diuretics, and to treat the other infectious etiology in case of development of spontaneous bacterial peritonitis. And hepatic encephalopathy, if the patient is in hepatic encephalopathy, the primary treatment is to patient should pass stools. So you have to give stool softeners or laxatives. So lactulose is given. The target is the patient should pass 2 to 3 stools per day.